I'm presenting a case study from our program in Pune, which is called the Seher Urban Community Mental Health and Inclusion Program. It's quite a mouthful, but it's worked for us. It's about 12 years old. And all those little logos you see are the different organizations which bring in different perspectives into the program and helped us make the transition from a mental health program to an inclusion program. So I want to start with just these provocative questions. Is mental health a health condition? Is it something that should feature in public health discourse? Or is it something that should feature more in the development discourse within the disability discourse? So very painfully, I would say, and also very strategically, I moved from being a mental health activist to a disability activist, and we also moved the Seher program and the Bapu Trust programs from healthcare to disability inclusive development. The shift was not easy, and there were times when there was nothing to do except wait for someone to recognize the importance, the strategic importance of this shift, and it's like really policy-linked shift. So I want to start with this preamble, bringing in. Renu has talked a lot about the convention. The CRPD is like the CEDAW and the CRC. It has full status as a legal convention. It is now 10 years old. And it brought some important insights to us when we were engaged with the drafting of the convention way back in 2005, 6 and 7. As Renu has said already, disability is not just the impairment under the convention. It is impairment and the social barriers. We are not sure yet whether mental illness and mentally ill, is that like a real disease or is that socially constructed? There are still raging debates on this. But this one kind of gives us a way out that it's a disability. Many of us who've gone through even depression would know that it's not socially constructed. I mean, you can spend days and days in a total black hole, and that you don't experience that like it's a social construct. So we did need a name for it. Mental illness did not serve a purpose because it had its own trajectory of over-medicalization, zombieism caused by psychiatric drugs, really insensitive doctors, mental institutions, and the whole colonial paradigm of people being incapable of anything at all. Indian laws today and the Indian case laws continue to use words like lunatics and idiots. You will find that very liberally splattered within the not just the criminal law but also family law and various civil laws. So it is good to escape from that kind of thing and come into this rather empowering discourse which recognizes that yes, social barriers, social deprivation, marginalization, exclusion, and not having the safety and comfort of experiencing your own self-identity in the way that you want to experience it, not having access to jobs, jobs, education, schooling, leisure activities, family, in whatever way you want to define it. And all of this can actually impact your mental health and lead on to disabilities. So it's really good to have the convention look at social barriers as definitive of the experience of disability. It's not something like, it's not like malaria and having a family problem. It's like in the very definition of psychosocial disability, the convention brought in social barriers as a factor. Equality is a cross-cutting principle, a core principle in the CRPD, along with non-discrimination, equality of opportunity, gender equality, accessibility, legal capacity, respect for human diversity, evolving capacity and autonomy. Each of these is jurisprudence and has been over the last 10 years of the CRPD has been amply and very eloquently defined by the CRPD monitoring committee which I believe is one of the most dynamic and active committees because they are largely people with disabilities. Coming to the question of healthcare rights, is healthcare the only way to enter access to support? If disability is impairment plus social barriers, then actually healthcare is only one of the ways for entry into care and support. There are maybe 25, 30 other ways, and the CRPD talks about a lot of them. So it's really important to know what is the entry point. What is the entry point into providing even healthcare services, but there are many entry points, and we'll come to some of that in our program. So treatment and being symptom free is not the outcome expected. If you look at the CRPD linked outcomes and programmatic planning, inclusion is the outcome, especially for highly marginalized excluded groups which willy-nilly enter the healthcare system for whatever reason. We would expect that the inclusion aspect will remain intact and it will not be grabbed away on grounds of incapacity, all of that. Until very recently, living in the community was taken for granted under the law. You will not find, even the Constitution does not talk about living in the community as a human right or as a fundamental right and freedom. Whereas the convention brought in Article 19, which for us in the Seher program and in Bapu Trust it's really our focus these days. Inclusion involves living in the community. Some people argue that a mental institution is a community program, and no, there is enough jurisprudence by now from the CRPD committee and by various other human rights council bodies, including the World Health Organization, which recently brought out in 2016 a comprehensive training kit called the Quality Rights Kit, which is unusually for the World Health Organization, is talking about deinstitutionalization as at the center of all policy making in mental health. The Disabilities Right Act of 2016, the Mental Health Care Act of 2017 have prominent provisions on living in the community as a full right. And so we feel that this is a really important development, and as people working from communities, we need to kind of harvest these opportunities within the law as much as possible. Implications for mental health programs. Seher has been around from 2004 onwards. We continue in about 12, 13 years. I believe there is a cost to making a transition from being a mental health service to a UNCRPD compliant inclusion-based service. There is a cost involved. The shift, as I said, is not easy. So some of the elements of the shift I have described over here. Before the CRPD, so there is a before CRPD and after CRPD period for the Seher program, where in the before period, the vision was to provide mental health support and reduce the burden of mental disorder. After the CRPD, create caregiving communities and have the outcome of inclusion. I think this is the major shift. And in the practice of it, because we work very much at the household level, in the practice of it, there have been many micro shifts which had to be established. So we have a learning cycle of, apply, study, learn, change. Apply, study, learn, change. In order to make this shift, and that process still continues. So these are some of the, with communities we had little direct engagement before, but now the communities own the program. So we are really directly, we act more as facilitators, enablers and capacity builders, but the program is held by communities and community people. Target is all stakeholders, particularly neighborhoods. We work a lot in clusters. And of course, we do have a population-based approach, but that's not only for targeted medical interventions or not even targeted psychosocial interventions. We do have targeted inclusion interventions. And so on. I don't want to spend a lot of time on this. Lohia Nagar map, this is an example. We are working now Yeah, and it's all, this is what we largely see in our communities, that the social barriers impacts mental health. Work in intersectional structural, with lot of intersectional structural barriers, poverty, lack of civic amenities, violence, hunger and starvation, age, work and employment, housing issues, migration, general health and nutrition. So we see a lot of all of this impacting mental health. This is a typical outreach of the Seher program every year. We have 5 community wellness centers with 3 full-fledged services. Population outreach is approximately 3 lakh people across 20 slums. We work intensively in some areas. We work out of the PHCs, but outside of the PHCs, we have several, like small community centers. It enables us to reach up to the household level. The Anganwadi system helps us a lot. The Urban Community Development Department, UCD department of the Municipal Corporation, they help us a lot. 350 people with low or high support needs are directly served by our program, and so on and so forth. There are many of these, and we offer choice, and so we have a number of segments within the program which are modular, so that depending on what the person needs, we are able to deliver that particular kind of service. The accent is on prevention, and a big part of our program is making people link up with available development services. And we are constantly engaged in negotiating communities for the prevention of human rights violations and making people access social justice systems. So this is the age distribution, and one of the things that I want to share here is there is a skewed sex ratio under 1 year and 10 years, and also about 60 years, 50 years and 60 years. Older men are difficult to see in the communities. There is rampant female feticide, and generally the loss of the missing girl children issue is very big in our communities. Alcohol, HIV, absolutely nil services for alcohol and de-addiction, very high stigma. Almost in some bastis where we work, the alcohol and other addictions are almost 70 to 75%. Absolutely no support. So men over the age of 50, they are not found in the communities. So they finish their work, and mortality rates after that is anybody's guess. There is not enough data on this. Single women post 40-45 are a big socio-demographic group, significant in itself in terms of cultural, social, economic and other specific characteristics. They are like 7 to 10%. We have a Pune atlas from where it is quite evident that a very high number of women are single women, which means that they have lost their husbands or they've been deserted or abandoned, but the bulk of them are single women through loss of spouse, mortality of the spouse. So there are lots of grieving issues, mourning issues, anger issues, lots and lots of emotional issues. Pregnant women, we work in the PHCs in 5 centers, and it attracts the women. It's a maternity. These are all maternity hospitals. We've kind of converted them into some parts of it into health and mental health, comprehensive health and mental health centers for all people in the slums, which itself was astonishingly difficult to do. PHCs were never meant to be just maternity wards, but they end up being that. And in Pune, the pregnant women come from all around, all the slum pockets around the PHC. So they are our biggest client group. We offer group support systems for them, and they suffer a lot because of the expectation that they will have a son, and they are the largest specific group of people availing our self-services. So we work a lot then with families and work with the healthcare system, where these women, their concerns about their relationship with family members, the expectations that family members place on them, those are not addressed by the healthcare system at all. This is the occupation of our, this is a typical slum where we have some census data, but largely this is the kind of population. Nearly 80%, 70 to 80% Dalit, Neo-Buddhist. The remaining are Muslim. So it's really the most marginalized of communities who occupy the slums. And there's an interesting paper which says that cities these days are divided on caste basis. I would also say that they are divided also on the basis of religion, because wherever we work, this is the kind of cultural background that we see. Dalit, Neo-Buddhist and Muslim. And so the population, they're basically the service sector for the city, and do a lot of work with their bodies. Domestic work, construction, labor, carpentry, masonry, marble work, stone works, city cleaning. A lot of this is, many of them are salaried within the government, like you have the Safai Karmacharis. It's a big population in this particular basti, whose characteristics I'm sharing with you. Many of them have petty jobs, and the bulk of them, many of them are 30%, many of them almost 25 to 30% in each slum, they are unemployed or having like extremely precarious employment. Again, shows gender discrimination. The highest number of unemployed people are the women, very often in caregiving. The rates of mental retardation and intellectual disabilities in our basti is really, really high, and I believe that it could be because of the very poor gynecological obstetric care that is received from the primary healthcare centers. And almost 1 in every 3 households has someone with intellectual mental disability. Epilepsy, mental disability is very, very high, unattended. Their healthcare is largely neglected. So, especially dental care, general infections, skin problems, and all the other associated healthcare problems of having a mental intellectual disability, cerebral palsy, the motor movements, motor wastage, muscle wastage. It's really scary what's going on within the primary healthcare system. Failure of so in fact we see mental health, this whole thing of mental health which we are offering, and there is a buy-in from the local authority on this. The Pune Municipal Corporation is a big partner with us. They've even released a annual budget line for us, which is very small compared to what we need to cover many bastis, but still their support is there. We find we are using the mental health gateway as a gateway for accessing general health care for a large number of people. So I do believe that it's the fundamental failure of the public health system which has led to this so-called alarming rise in mental disorders. And so we are covering for that in our own way by bringing as many people as possible within our client groups, and it's a large group, and in a number of bastis into the general healthcare system, the comprehensive healthcare system. So almost 70 to 80% of our clients go through general health check, and they get cover for the other kinds of, particularly malnutrition, anemia, TB treatment, HIV. And sometimes, the chronic diseases. But this is the bulk of the health problems that are generally neglected. And the access to primary health care is largely only for maternity services, pre-delivery, delivery, post-delivery, that's it. So lots of psychosomatic issues due to daily labor, pain, malnutrition, severe anemia, infections. Every third household would have someone with a psychosocial support need, typically depression or anxiety, because we've captured over the years a number of cultural linguistic expressions of emotional distress, like for example dard, bad. So there are many of these expressions which signify to us that there is a psychosocial issue involved. Over the years, we have churned out our own tools, and so we don't get into the medical arena. So in the case of people who have a high support need, like they are hearing voices or they are wandering or something, the first step is always comprehensive health care. And we have to really negotiate with the PHC system that guys, these guys have a malnutrition issue. Can you address that first? And then all the other, they have a home housing issue. They need clothes, and you have to say this within the development sector and the primary healthcare sector. It's really a hard negotiation with the doctors and with the system to ensure that many of the development needs are covered for as many of our clients as possible. People with high support psychosocial needs, especially voice hearing and homeless and wandering people, they are the highest number registered into our program, and they stay on longer. People with low support needs, they move on, they get by, but people with high support needs, they linger on in our system and for a long time. And they are used to be pushed into the colonial type closed door penal lockup facility using the state machinery. We have only one, thankfully so, for the poor. The rich have a number of such lockup facilities, which are paying facilities. I say that mentally ill people are the only ones who pay to get arrested and put away. So those we don't know about because they are quite unregulated. And the recent mental health care bill does not cover the aspect of coercion or involuntary commitment into mental institutions. These colonial stereotypes continue to haunt the mental health sector. Institutionalization, when one of our clients gets into these institutions willy-nilly, it cuts off all access to development services, food, family, social contact, and any kind of, and healthcare needs, general healthcare needs are highly neglected within these systems. High mortality, risk of being abandoned, and coming into other penal institutions. Like we also have in Pune the beggars' homes, so you might also find them ending up over there, zero healthcare. So for us in the Seher program, prevention of institutionalization is an important strategy, working with neighborhoods to support the person and to set up a circle of care for the person. So we have the multi-dimensional community mental health and inclusion program that helps in negotiating care at the household level and with the systems up to a point. So this is our framework. I'll stop with this. So are we doing the work that the governments are supposed to be doing? Yes, of course. So, and the present policies are not going to change that. The present policy, mental health care bill is not going to change that. So thank you all for your patient listening.